So what are our treatment goals for patients with lower limb malperfusion combined with diabetes? Well, we really want to stop the patient losing their limb, but for me as a clinician in the hospital, I want to make sure they survive whatever insult we put them through and are discharged to a well environment with ability to progress long term and continue their normal quality of life. So peripheral arterial disease, as are all clinical conditions, we really have a lot of guidelines. In fact, often they're excessive, but they are important to give us an indication of where we need to be with gold standard for patient treatment. For us, especially in peripheral arterial disease, the Transatlantic Society Consensus Guidelines are essential, and but I do believe these are now starting to become outdated, particularly with endovascular intervention, as these were published in 2007. Unfortunately, the Task 3 guidelines did not have a consensus due to what is perceived to be a lot of industry input, and as such, the Task 2 is still what we are using at this moment in time. So Task 2 guidelines talk about a lot of epidemiology, how we investigate acute and chronic disease, and what imaging we should use. It also delineates levels of evidence, and if we revise levels of evidence again, which you need for some of your other modules, really meta-analyses or at least one randomized controlled trial is good quality level 1 evidence. If we look at controlled studies, or at least other types of quasi-experimental evidence, this is grade 2 evidence. And then evidence from non-experimental descriptive studies, correlation studies, comparative studies, case controlled is level 3. And then clinician opinion or expert opinion is level 4 evidence, and really is quite open to a lot of bias. So when we look at levels of evidence, the levels of evidence then delineate what way we can recommend the treatment. So if you have high quality evidence, level 1A and level 1B, that could suggest that if you've got a definite clinical effect from an intervention, that could be graded as grade A evidence, which is usually high quality evidence to address and recommend a specific treatment plan. When we look at treatment, well, conservative. It's not relating to any intervention that I'm going to do in the operative room. We want to look at, there's nothing we can do with gender. I want to try and get the patients to reduce their smoking habit, and at this moment in time, I believe NICE still suggests that we're allowed to use e-cigarettes. However, I do worry about e-cigarettes are still produced by the tobacco companies, and the vapor itself does worry me for ocular toxicity in the long term. And you want to look at hypertension. Smoking cessation is absolutely vital, but one thing that's quite interesting about smoking cessation, the actual clinical evidence that we have is extremely lacking for smoking cessation, because nobody's really done a randomized controlled trial which is blinded, where one group were told to smoke loads and the other group were told not to smoke. It's all related to case control or comparative studies or retrospective reviews, where we do know that if you smoke, you have a higher proportion of vascular disease and poorer outcomes. Exercise rehabilitation is absolutely vital, and indeed in my clinic I tell all my patients that they should walk for 30 minutes every day. The patients are often aghast at that, but I do suggest that this is something that they need to work to. So if you're an athlete, you're not going to suddenly run 100 metres in 11 seconds or less. You do need to train up to that, and our patients need to be aware that this takes time. It's also important to realise that if you can walk for 30 minutes every day, that you will be as good as a balloon angioplasty at 6 months. And again, I reinforce that with my patients as well. Medical treatments include antiplatelet therapy, and again, all our patients should be on some sort of antiplatelet treatment with aspirin or clopidogrel, and again, there's grade A evidence for this. But why do we prescribe aspirin? I ask a lot of my senior vascular trainees who are about to do their consultant exams, and some of the answers are either lacking or very poor. One of the things is aspirin hasn't been shown to dramatically improve lower limbs. What aspirin actually does is we know that it affects our overall cardiovascular burden. So we know that if you prescribe aspirin, you get a big reduction in myocardial events, cerebrovascular events, and death rates in patients with peripheral arterial disease. And indeed the Capri registry, which was industry sponsored, does suggest that clopidogrel has added benefits as well. Remember, dual antiplatelet therapy is indicated in patients with infrainguinal endovascular procedures, and I actually have dual antiplatelet therapy if I've had a difficult bypass or even redo surgery where the previous graft is occluded. Hyperlipidemia. Well, patients get their cholesterol measured. If some of the subgroup portions are elevated, they get commenced on treatment, which may be a statin or fibrate. My overall ethos in vascular is that if you have peripheral arterial disease, which is causing claudication or even critical ischemia, regardless of your cholesterol homeostasis, you need to be in a statin for their added inflammatory effects. They are shown to cause some element of plaque regression, albeit that's in scientific studies, but some studies have shown that statins can improve walking performance. So why prescribe statins again? This is the Medical Research Council has recommended statin therapy, and again this is due to reduction in the global cardiovascular risk profile. But again, as I've stated, walking improvements can occur with statins. So, interestingly, we know that patients with diabetes have more severe disease processes. They've got worse outcomes, but evidence for glucose homeostasis being optimized is actually grade C. I'm not entirely sure why it's grade C, but for me, I know that we need to optimize glucose homeostasis in our diabetic patients to limit end-stage diabetic outcomes that are deficient for the patient. Peripheral arterial disease specific pharmacotherapy was very abundant even up to 10 years ago, and indeed my own doctorate reviewed a phosphodiesterase inhibitor called cilostazol, which was Playtel, and its effects in improving walking distance, which I believe it did. However, subsequent cost analyses and cost modelling has suggested that it's not worth the cost. Therefore, naftafural praxilene is very cheap and it is considered, but in 18 years since qualification in 1999, I've yet to prescribe one patient with naftafural. There's no recommendation for the use of pentoxifene. So when we look at my own doctorate data, initial claudication distance over 6 weeks and 24 weeks where the patient first described discomfort did improve with cilostazol, but it wasn't significant. However, absolute claudication distance, which is where the patient walks to their limit, was significantly improved both as early as 6 weeks and 24 weeks, and I do miss the ability to prescribe cilostazol. I've recently been involved in compilation of a book chapter for peripheral arterial disease specific medical therapies, and there's a huge list of treatments that we can use. Some of these are health treatments such as ginkgo, and some of these are cardiac drugs. My own personal feelings from being involved in gene therapy many years ago is that we targeted a single factor in the gene therapy cascade, and the study I was involved in, called the WALK study, we targeted hypoxia inducible factor. My overall feelings is that if gene therapy is to be a success, we need to target multiple gene mechanisms, or even go back to basics with stem cell therapy to try and glean outcomes. However, these studies are very expensive and they do require a lot of planning because we don't really know the long-term effects of gene therapy. When we look at procedural intervention, we can perform this both with endovascular surgery modalities. It is important just to revise that patients need to be fully aware of complications that can happen. And I actually tell patients that whenever they come to my clinic with 500-yard claudication, I do quote them a limb loss risk, albeit it's between 0.1 and 1%, but it's not zero. And if you take someone who can walk for 20 minutes, do an endovascular procedure, it fails, and they end up losing their leg, you're either going to be in the courthouse or you're going to, as well as having a very disgruntled patient. So general complications include some discomfort, bruising, bleeding, and of course wound infections. You've always got to worry about cardiovascular, respiratory, and thromboembolic systemic complications. And in particular, to any procedure to improve blood supply, you worry about your graft being infected or occluding, consequences of nerve damage, which happens with any surgical wound, failure to improve symptoms, and of course, limb loss. So endovascular treatment has exploded in the last 20 years, and indeed some of the things we can now do with small wires, balloons and stents does open up a whole new category of intervention, particularly to high risk patients who would not have been fit for operative bypass. When we look at acute limb ischemia, to just digress again, we just need to know that we have to act very quickly in acute limb ischemia. It's always nice to evaluate the contralateral limb. If you've got a full set of pulses on the left lower extremity with an acutely ischemic right lower extremity, that would suggest that this is maybe not known peripheral arterial disease with thrombosis in situ, but probably an embolic phenomenon. Get heparin started early, sometimes it can really help. And also, if there's any tenderness in the calf and you think about fasciotomy, just do it. Surgical intervention is normally you need an A, B and a C. And what I mean by that is A is your inflow vessel, which is normally the aorta, iliac or femoral vessel. And then B is your conduit, which we try and use vein as much as possible. I believe in do the best operation the first time, but failing that, prosthetic grafts are indicated. And then C is our outflow vessel. And if you've got patency of an outflow vessel where you know the blood is going somewhere, then you have a chance for your graft to last and remain patent for a period of time. However, if you have no patency of any vessels in the below knee segment crossing the ankle, it is highly likely that your bypass will never be effective and will fail quickly and indeed put the patient at added risk. When we look at surgical bypass, we want to try and harvest the great venous vein, usually on the same leg. We want to expose the groin for the common femoral artery, and we control the superficial femoral and profunda femoris arteries. We then create a vein tunnel, which is usually in the subfascial plane, and if you do this below the knee, you normally go beneath the muscle itself to try and limit any acute kink in a superficial graft, diving deep just below the knee. You then complete your proximal anastomosis. You check your flow rates, and once you're content that flow rates are satisfactory, you can do your distal anastomosis prior to restoring normal blood supply. So why do we treat diabetic foot disease? Why are we so interested in trying to evaluate these patients prophylactically, keep them going for as long as possible? Well, we want to stop amputations because they're an absolute disaster and they're a huge socio-economic burden on healthcare in general. However, despite our best efforts, amputations do still occur. They occur in often compliant and also non-compliant patients, and smoking still remains a scourge. So when we look at amputations, well, peripheral arterial disease really accounts for the majority of lower limb amputations, particularly in the Western world. It's 6 times more prevalent if you've got diabetes, and there are epicenters, particularly where I used to work in the Mayo Clinic in Phoenix. 70% of all lower limb prosthetic referrals are really related to a vascular mechanism for the initial amputation itself. When we look at some European data, there are modern advancements in surgery, and I believe particularly in best medical therapy, has caused a reduction in major limb amputations, and this has been reported in other Western countries. However, it's important to realise that survival following an amputation is bimodal. And what I mean by that is that if your patient has an amputation due to a traumatic episode, it's all about whether they survive that trauma itself. So if the patient survives a trauma without any cardiovascular risk, they have a good chance for long-term survival. In this case, you can see this is bomb injuries from many years ago in Belfast, and you can clearly see that this is a massive hit to the patient. There's a lot going on this slide, where you've had a crash above knee amputation without closure on the left side. On the right side, the surgeons are trying in vain to save the limb, and indeed there are a number of orthopedic injuries, and blood supply is continuing via shunts prior to completion of external fixation, which you can see one of the surgeons with a screwdriver for external fixators in the top left hand of the screen. And once the orthopedic portion is completed, the vascular surgeon then performs their bypass procedure or repair accordingly. This patient survived, but significant injuries. So for peripheral arterial disease, again, it's all based on cardiovascular load. If they have a very bad cerebrovascular, cardiovascular system, that will usually be the cause of their underlying demise rather than their lower extremities. So it's really what lies beneath in our patients. So outcomes following major limb amputation are still dreadful. We have 10% or more 30-day mortality, and that's for the global spectrum, particularly when you do crash amputations in emergent patients in their 9th or even 10th decade of life. However, long-term survival is still bad, with 60% surviving 1 year, and this drops significantly in 5 years. And that's really the systemic manifestations of cardiovascular disease that catch up with our patients. So surgical philosophy, well, emergencies do occur, and emergent status of the patient does increase the risk. The spectrum of disease severity, a grossly septic limb will not do as good as someone with a small ulcer that's non-healing in a few digits. The overall patient condition and whether or not you can restore blood supply. And it's also important to realise what is rehabilitation potential. And in my practice, I call a one-stop shop, where I have a high-risk patient who has never mobilised for maybe 5 or 10 years. I will tend to try and do an amputation at a level that will preclude any further surgery for that patient. And unfortunately, above-knee amputation is often required in that patient population.